A very good morning to everybody and welcome to our DeBakey Heart and Vascular Center Cardiology Grand Rounds this morning. I'm Arvind Bhimaraj. I'm the Interim Division Chief for Heart Failure at Houston Methodist Hospital. And in the studio here with me is Dr. Mahvash Kasi. She's the Director of our Cardiac Sarcoid Program. And I want to welcome you all for a very exciting talk today. Before I get the honor of introducing our Grand Round speaker today, I want to remind everybody to send in questions as you watch the Grand Rounds. We will be able to address them at the end of the Grand Rounds. It's pollev.com and you enter DeBakey and you can just type in on the web, or you could text DeBakey to 37607 because I'm sure this is an area where there are a lot more questions, and Dr. Solomon's expertise in this area is phenomenal. So that brings me to my honor and pleasure to welcome and introduce our Grand Round speaker today, Dr. Scott Solomon. He's the Edward D. Frohlich Distinguished Chair and Professor of Medicine at Harvard Medical School. He's a Director of Clinical Trials Outcome Center at Brigham and Women's Hospital from Boston. We were just chatting that we would have loved to have him, but with the current pandemic and other challenges, we're at least appreciated we're able to use technology in the current world. But Dr. Solomon is a world-famous clinical trialist. He's really been a pioneer in running so many large trials that have changed the landscape of medical care, especially in heart failure. He currently directs the Clinical Trials Outcome Center and also the Cardiac Imaging Core Laboratory. His research interests in his lab had studied changes in ventricular structure and function following myocardial injury, modifiers of risk and influences of outcomes in patients following myocardial infarction and chronic heart failure. His introduction can probably be a grand rounds by itself to just list the number of trials that he has contributed to. But just a few recent highlights that I can quote is the first positive phase 2 trials in HFpEF and the Paragon Heart Failure, Deliver, and Fine Arts Outcome trials definitely are certain credit to his leadership and his investment in a field which is really had been a nuance for us as clinicians and heart failure cardiologists. And today he's going to take up this challenging topic and enlighten us and talk about heart failure and the mid-range ejection fraction, heart failure with preserved ejection fraction. So we're very honored to have you talk about a topic which we're very excited to learn. Over to Dr. Solomon.
Arvind, thank you very much for that kind introduction. And I'm going to go ahead and share my slides. Let me know if you see them.
Yes.
And it's really an honor to come back to Methodist. I've been there, I was just saying, about 15 or 20 years ago when Doug Mann was the chief. I know there have been a lot of changes since then, but I hope to get back at some point when this pandemic is at least behind us to some extent. I'm very happy to be able to give you a talk today that I'm going to call Heart Failure with Mildly Reduced and Preserved Ejection Fraction, Light at the End of the Tunnel. I used to talk about a disease in search of a therapy, and it's great to at least finally have some potential options that I'll talk about for this difficult group of patients to treat. These are my disclosures. Let me start by just reminding everybody that we have about 7 million people living with heart failure in the United States with an incidence of about 1 million people a year. This is going up because as the population ages, we have more and more patients with heart failure. Heart failure is a disease of aging, and we predict that by 2030, this will be considerably higher with a cost to the healthcare system that will approach $50 billion a year. It's one of the single most important contributions to healthcare costs. And Eugene Bromwald, who's been one of my main mentors for the last 35 years says that heart failure is the price that we pay for the successful treatment of heart disease. And in many respects it is. Well, how do we define heart failure? I'm going to show these because I think that in the context of this entity we call heart failure with preserved or mildly reduced ejection fraction, it's very different from our typical thinking about heart failure. If you go back to 1933, Thomas Lewis described heart failure as a condition in which the heart fails to discharge its contents adequately. That was then followed by Paul Wood in 1950 saying heart failure is a state in which the heart fails to maintain an adequate circulation for the body despite a satisfactory filling pressure. Gene Bromwald in 1980 called heart failure a pathophysiologic state in which an abnormality of cardiac function is responsible for the failure of the heart to pump blood at a rate commensurate with the requirements in the metabolizing tissue. But it's important to remember that it really wasn't until the mid-1980s when we began to appreciate that a patient could have this clinical syndrome that we called heart failure without having a clear abnormality of contractile function. In other words, our primary metric of cardiac function, ejection fraction, did not appear to be the problem in about half of the patients with this clinical syndrome of heart failure. So I like this definition, which is much, I think, closer to the current universal definition of heart failure, the inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only in the setting of elevated filling pressures. And we all know that this clinically translates to a syndrome characterized by breathlessness, fatigue, and edema caused by an abnormality of the heart. And I say caused by an abnormality of the heart because we all know there are other things that cause breathlessness, fatigue, and edema. So we've had two phases of heart failure for many years now. The patient on the left is one that we understand very well. It's a patient with a dilated, dysfunctional left ventricle. If that person showed up in your emergency department with rales and pulmonary edema and short of breath, you would know what's going on. But if the patient on the right showed up with the exact same signs and symptoms, we'd be more hard-pressed to understand what is happening with that patient because their ejection fraction is completely normal. The patient on the left, of course, has heart failure with reduced ejection fraction, or we call that Hephref, and the patient on the right has heart failure with preserved or HFpEF. Now, between about a third and a half of all patients with heart failure who are admitted to the hospital with heart failure end up having an ejection fraction that is not reduced. In other words, over about 40%. We're going to talk a bit more about where these cutoffs are and or maybe should be. But it turns out that these patients have virtually the same signs and symptoms as the patients with heart failure with reduced ejection fraction. And these are data from the CHARM program, which is a clinical trial we did a number of years ago, where we enrolled patients across the full spectrum of ejection fraction, but set a line in the sand at 40%. And the patients who had an EF that was under 40 went into the CHARM reduced trials, and the patient who had an EF over 40 went into CHARM preserved. And it turns out that the preserved patients have edema, they have orthopnea, they have PND, rest dyspnea, crackles, elevated jugular venous pressure. They don't tend to have S3s or cardiomegaly. That's the main difference. HFpEF is certainly increasing in prevalence, and this is particularly true in the US, and particularly true in two demographics, women and African Americans. These are data from Patty Chang from the Atherosclerosis Risk and Community Surveillance study. Now, how do we diagnose this? And I'm just going to fairly briefly go through this before we talk about therapy, because in order to define who are the patients that we want to treat, we actually have to figure out if we can identify them. And of course, there's been a lot of controversy regarding diagnosis of patients with heart failure with preserved ejection fraction. I'm a purist, and in my purist mind, I think you only really need two things to make this diagnosis. You need to know that the ejection fraction is preserved, and we'll talk about what we mean by that. And you need to know that the patient has heart failure. Unfortunately, neither of these is quite as simple as we think. So how do we make that definition of preserve? Well, I'm going to just take you back and remind everybody that the cutoffs that we currently use in heart failure to designate heart failure with reduced versus preserved versus other nomenclature like mid-range, these were based for the most part on clinical trials that define patient populations whom to include. The early trials in heart failure, of course, trials like Solved and Rouse, Merit-HF, they had ejection fraction cutoffs, either 35 or 40%, and it became convention that we called heart failure with an ejection fraction that was under 40% or sometimes 40% and under heart failure with reduced ejection fraction. When we did the CHARM study about 15 years ago, we needed a name for the patients who did not have heart failure with reduced ejection fraction, and we called it heart failure with preserved ejection fraction. That was actually the way that term was coined. But there's been a lot of controversy, as you know, about whether that should be the definition for preserved, whether it should be 50%. Trials have used various cutoffs, 45%, 50% in some cases. And it got even more complicated over the last few years because the ESC came out in 2016 with a whole new category, heart failure with mid-range ejection fraction, in this 40 to 50% range. Unfortunately, I take some of the blame for that. In 2014, Carolyn Lamb and I coined that term, heart failure with mid-range ejection fraction, not specifically because we wanted to create a whole new category, but we really wanted to call attention to these patients who had been somewhat neglected in that middle range between 40 and 50%. And then in 2016, the ESC guidelines came out with this definition. Now, the problem, of course, with making a new category is that it gives you another cutoff. And I don't like cutoffs in biology because, frankly, I think there are no real cutoffs in biology. These definitions are completely arbitrary. And we also know that if we were to take patients and assess their ejection fraction, here's an example of that. We have 100 people whose ejection fractions fall between 40 and 50%, and then we remeasure them in the exact same laboratory by the same people, and we'll get about 40% of them outside of those ranges. And so this, I think, makes, especially with a relatively high variability measure like ejection fraction by echocardiography, we end up with a lot of splay. And so I think it's somewhat dangerous to be applying a cutoff at the bottom end and a cutoff at the top end to this category. Now, what about the diagnosis of heart failure? I don't need to tell any of you how to do that. You're obviously expert at it. We use a combination of signs, symptoms, and exclusions. In other words, excluding other reasons that our patients have breathlessness and fatigue and edema and so forth. But there are a lot of pitfalls when making the diagnosis when ejection fraction is preserved, because we know that many of the signs and symptoms can be nonspecific. We don't want to incorrectly diagnose people who are simply unfit with swollen ankles. Unfortunately, our physical exam skills are waning. Even estimating jugular venous pressure, especially in obese patients, can be very challenging. And as we all know, the differential diagnosis of dyspnea and edema is broad, includes many cardiac diseases, including lung disease, anemia, iron deficiency, even without anemia, hypothyroidism. The list goes on. So many of us have advocated for using biomarkers as a way to help us make this diagnosis. Natriuretic peptides, of course, are increased in the setting of increased wall stress. And there's been many studies now that have shown that NT-proBNP or BNP elevation is a very important predictor of outcome in patients with heart failure with preserved ejection fraction. And currently, most of the clinical trials that have been done, at least in the last decade or so, with heart in this area have utilized natriuretic peptides as inclusion criteria. And of course, many of us use that as a way to determine if our patients who present with unexplained dyspnea have a problem with their heart or not. Now, there are, of course, caveats when we use natriuretic peptides. As we know, atrial fibrillation increases natriuretic peptides even in patients without heart failure. This is one of the reasons that many of the trials that we do have raised the natriuretic peptide entry criteria by 2 or 3-fold in patients with atrial fibrillation. Obesity lowers natriuretic peptides and changes the relationship between a particular level of natriuretic peptide at risk, as does black race. Important to consider these when we have specific patients in front of us. There have been a couple of scores that have been advocated and in one case at least validated for patients with HFpEF. On the left is the H2f Pef Score, which came from work done by Barry Borlaug's group at the Mayo Clinic. It's basically a very simple point score that gives you points for a number of things, including body mass index, number of hypertensive medications you're on, whether you have atrial fibrillation or not, Doppler estimation of pulmonary pressures, age, and Doppler estimation of filling pressures. That's been validated against invasively assessed filling pressure in patients who underwent right heart cath. The HFA Pef score from the European Society of Cardiology was not validated. It was not based on actual data, but by expert opinion. There are a number of major and minor criteria that are used. I'm not going to go through this, but I would have to say that I'm not really a score guy. I won't remember all of these very easily. And as I said before, I think that a more simplistic approach is that you are convinced that you have signs and symptoms of heart failure, that the ejection fraction is greater than 40%, and that you have some additional assurance that a patient has elevated filling pressures. The easiest way to determine that is natriuretic peptides, but of course, if you have a right heart cath, you can use that. I like to know that there's evidence of structural heart disease, that there's something wrong with the patient's heart. And what we've done in a variety of clinical trials now is used either left ventricular hypertrophy or left atrial enlargement as a marker. It's easier to use than Doppler measures, but in places like Methodist DeBakey, where you are really good at Doppler assessment, then that can obviously be helpful as well. You want to exclude other non-cardiac causes of signs and symptoms, and also you want to ultimately exclude specific diseases that are potentially targetable. And specifically, I'm talking about amyloid heart disease and hypertrophic cardiomyopathy. Now, the reason I'm calling these two out in particular is because, first of all, they are due, as we know, to specific molecular mechanisms. In the case of HCM, it's sarcomeric mutations leading to unexplained ventricular hypertrophy and myocyte disarray. In the case of amyloid, it's usually either a genetic or wild type misfolding of transthyretin amyloid. The reason that it's important to pull these patients out of the broader pool of patients with HFpEF is that there are now targeted treatments for both of these conditions. Mavacamten, a myosin inhibitor, has recently been approved for use in hypertrophic cardiomyopathy. And tafamidis is currently available for patients with transthyretin amyloid. This is a TTR stabilizer, and there are other TTR knockdown agents that are also being tested and should be available relatively soon for this population. So important, I think, to pull these people out. Now, some have argued that HFpEF is really not a disease. It's simply a collection of comorbidities, because we know that these patients are much more likely to be older, have hypertension, have diabetes, have atrial fibrillation, COPD, anemia, and some have said, okay, there's no disease there. This is simply a collection of other things. I don't think that's true. And I don't think that's true because when you look at the event rates in clinical trials that have enrolled people with all of those other comorbidities, like hypertension and coronary disease and vascular disease and diabetes, you see that they're much lower than if you look at the event rates in patients who were enrolled who specifically had signs and symptoms of heart failure. So clearly, and this is true both of heart failure hospitalizations and mortality, there is something about transitioning into the heart failure club that becomes important. Now, what causes heart failure, preserved ejection fraction? It was really convenient when we were able to talk about systolic heart failure and diastolic heart failure. This is what we called this entity 25 years ago, because it seemed very reasonable that we had a problem in patients with heart failure with reduced ejection fraction, a problem of systole, and in these patients, the problem maybe was all about diastole. And of course, we're all familiar with the fact that in a patient with a stiff heart, the pressure volume curve is shifted upwards and to the left. This is clearly true of many patients with heart failure with preserved ejection fraction, as was shown in this important paper by Mike Zeil in the New England Journal in 2004. The problem is, as you know as well as anybody, that diastolic dysfunction is actually quite ubiquitous in elderly people, especially as you collect comorbidities like hypertension and diabetes. These are some data from Maggie Redfield showing that about 50% of all patients with hypertension have evidence of diastolic dysfunction. And we know that if we look at metrics of diastolic function like lateral mitral annular relaxation velocity, or E prime, these decline with normal aging. And so as patients get older, diastolic function gets worse, even in people who don't have heart failure. We've looked at this in the ERIC study, where we were able to do a quantitative analysis of over 6,000 people in 4 different communities in the United States. And if you take out the patients who are truly healthy, now they're elderly because this exam was done between ages 65 and 85. But if you take out the completely healthy people without diabetes and hypertension and coronary disease or heart failure, there aren't a lot of them, but they have a fairly substantial amount of diastolic dysfunction based on standard ASC criteria, not as much as the patients who have overt heart failure, but it makes you wonder that these patients clearly have enough diastolic dysfunction that you would say, if this is the only reason that these patients have, that if this is the cause of heart failure with preserved ejection fraction, then we should see it in many, many more people. Well, we and others went back and looked at systolic function with myocardial strain imaging. I know you're quite familiar with that. And what we've found is that even in patients with preserved ejection fractions, even normal ejection fractions, we saw abnormalities of systolic function, evidenced both by changes in longitudinal strain and changes in circumferential strain. Here are normal patients, and these are both longitudinal strain and circumferential strain in green, longitudinal strain in red. And we can see that as you progress from hypertension to diastolic dysfunction, we see abnormalities of longitudinal strain, but not necessarily of circumferential strain. But in patients with heart failure with preserved ejection fraction, this has been now repeated in a number of other studies as well. We see abnormalities of both longitudinal and circumferential strain, not anywhere near as bad as we see in patients with heart failure with reduced ejection fraction. So it is a matter of degree, but clearly systolic function is abnormal here. And when we looked at a variety of echocardiographic and other predictors of outcome in patients with heart failure, we saw that global longitudinal strain, a measure of systolic function, was the single best predictor of outcome in these patients. Interesting. Now, we also like to believe we understand what causes our diseases on a molecular level in 2022. Unfortunately, we are not quite there yet. There have been a number of theories and concepts for why we have this abnormality in patients with heart failure with preserved ejection fraction, usually relating to worsening of diastolic function. This includes dysfunctional calcium handling, abnormalities of the spring-like titin protein. Titin is, of course, as you know, the longest protein in the body and serves to restore the sarcomere to its resting length. Abnormal phosphorylation in titin can play a role in worsening diastolic function. We know that diseases like diabetes and hypertension lead to increased extracellular fibrosis and collagen deposition, which can reduce the ventricular compliance and shift the volume pressure relationship. The most recent concept du jour in heart failure with preserved ejection fraction has been an inflammatory model in which comorbidities such as obesity and diabetes and hypertension lead to systemic inflammation, which leads to the generation of reactive oxygen species, reduced availability of nitric oxide, which tends to reduce cyclic GMP, reduce phosphokinase G, which is responsible for hypertrophy and myocyte stiffness. It's a really nice idea and concept, and the data supporting this are unfortunately relatively limited. This may be a mechanism in at least some patients with heart failure with preserved ejection fraction, but it's hard to argue that it's likely to be everyone, especially because many of the diseases that we know are common in this population are associated with inflammation. So this could be an epiphenomena, or it could be causal, but probably over a very long period of time. So how do we treat heart failure with preserved ejection fraction? For many years, I think we've been between a rock and a hard place. And if you go back to 2016, the last time the New England Journal published a review article on HFpEF, the treatment was essentially empiric. Consider alternative diagnoses, symptomatically treat with diuretics, lower blood pressure, treat other comorbidities, rate control in atrial fibrillation, diagnose and treat ischemia. Now, we have been trying to find therapies in heart failure with preserved ejection fraction almost in parallel with doing so in heart failure with reduced ejection fraction. And of course, we started with the therapies that had proven successful in Hephref, the renin-angiotensin-aldosterone system inhibitors that we know so well and that we've used for many, many years in our patients with heart failure with reduced ejection fraction. And here are the 4 outcomes trials that have tested RAS inhibitors, CHOM Preserve, PEP-CHF, iPreserve, and TopCat. None of them made their primary endpoint, although several of them came pretty close, including CHOM Preserve and TopCat. If we were to take all of these and put them together in a meta-analysis, we see a modest but significant overall reduction in a composite endpoint of cardiovascular death or heart failure hospitalization by about 11%. Not a whopping treatment effect, but it appears to be something, and it appears to be real. TopCat probably came closest in some ways, although we know that when we unblinded TopCat, we saw 2 distinct patient populations. We enrolled people in TopCat in the US, Canada, Argentina, and Brazil, but also in Russia and the Republic of Georgia. And in Russia and the Republic of Georgia, the event rate in these patients was about a fifth of that in the Americas. And so we believe that many of these people didn't actually have heart failure. And if they didn't have heart failure, they weren't going to benefit from a heart failure therapy. We can see in the people who did appear to have a trajectory that looked like heart failure, there was a nominal 18% risk reduction. Now, of course, this is a post hoc analysis of a clinical trial, so we have to be very careful in its interpretation. We've also know well that spironolactone, which is a drug we've all used for many, many years, is associated with increased creatinine and hyperkalemia. And what we found in TopCat was that as GFR went down, the efficacy of this therapy went down, possibly because of much greater discontinuation, but also the safety it also was worsened. And so we see that there's more risk associated with treating patients with a lower GFR and less benefit. And so we have to be very cautious about doing that, even though spironolactone has a class 2B indication in the current guidelines. Now, one thing that we've also learned through these trials is that if there's any efficacy in patients with HFpEF with RAS inhibitors, it has been mostly in the lower end of the ejection fraction spectrum. So that middle range that we've been talking about is where we see the greatest treatment effect, both in the TopCat trial and the exact same thing in the CHARM study. So the patients with heart failure with mildly reduced or mid-range ejection fraction seem to be deriving the greatest benefit. We've been studying for about 12 years sacubitril/valsartan, first in heart failure with reduced ejection fraction and subsequently in HFpEF. And as you know, sacubitril/valsartan is a angiotensin receptor neprilysin inhibitor that simultaneously blocks the renin-angiotensin system and also blocks this enzyme neprilysin, which is responsible for the breakdown of the biologically active natriuretic peptides like ANP, BNP, and CNP, variety of other peptides as well. And so when you give it, you're simultaneously blocking the renin-angiotensin system, and you're also augmenting the naturally occurring vasoactive peptide system. At the same time we designed and conducted the paradigm trial on Hephref, we were doing the first pilot study in this with this therapy in HFpEF. This was called Paramount, and we were able to show in about 300 patients that we could lower NT-proBNP, which is a good marker of severity of heart failure, even in the setting of neprilysin inhibition, because it is not a substrate for neprilysin. We were able to show reduction in NT-proBNP, reduction in left atrial size, and improvement in New York Heart Association class in this phase 2 trial. And based on that, we went ahead and designed a phase 3 trial, taking into account many of the lessons that we had learned from previous studies, including TopCat, including taking into account that we wanted to assure ourselves that these patients truly had heart failure by ensuring they had structural heart disease or elevation in natriuretic peptides. It was an active controlled trial because we didn't believe we could remove patients from their RAS inhibitors. About 85% of our patients were already on RAS inhibitors in this trial. And it was a large 4,800 event-driven study. So I presented these results almost 3 years ago at the ESC in 2019, and we had fewer total hospitalizations for heart failure. This was the primary endpoint, or cardiovascular deaths, in the sacubitril/valsartan arm compared to the valsartan arm. As you can see here, about a 13% reduction, but we just barely missed statistical significance. The upper bound of this confidence interval is 1.01, and a p-value of 0.059. I can't tell you how frustrating that is for a clinical trialist when you get that close because you know that, in fact, we calculated that about 7 events would have flipped this, 7 events in the other direction would have flipped this. So you realize it probably is a bit of a power issue. But we saw a fair amount of other evidence of biologic activity and benefit. We saw more patients had their New York Heart Association class improved and fewer worsened in the sacubitril/valsartan arm, with a 45% increased odds of improvement in New York Heart Association class with a nominal p-value here of 0.004. We saw more patients had benefit in terms of a 5 or more point increase in the Kansas City Cardiomyopathy Clinical Summary Score, a measure of quality of life. And we saw a 50% reduction in a composite renal endpoint consisting of renal death, end-stage renal disease, or a 50% decline in GFR. But we also saw evidence of heterogeneity, just like we had seen in the TopCat trial and the CHARM trial. The patients who had ejection fractions below our median of 57% saw the greatest benefit, and we saw declining benefit as ejection fraction went up. This is the same pattern we saw in those other 2 trials I already mentioned. When we put these data together from Paradigm and Paragon in a pre-specified pooled analysis of over 13,000 patients, we can see that if you do very large clinical trials, you actually have a lot of power. And if we had done this study as one large trial, we would have seen significant benefit for every single outcome listed here, including all-cause mortality. And we might have concluded this drug works completely across the full spectrum of heart failure. But when we look at the benefit across that spectrum of ejection fraction, so EF on the x-axis and the treatment effect on the y-axis here, we see that there is a decline in the benefit as ejection fraction goes up. This decline is true in both men and in women, but it appears to, we appear to see greater benefit to a higher ejection fraction in women compared to men. If we look at this in terms of absolute risk reduction overall in Paragon, we had about half the absolute risk reduction that we saw in Paradigm. But if we look only in the patients with an ejection fraction below the median, again, 57%, we see almost the identical absolute risk reduction as we had seen in Hephref in the Paradigm trial. So armed with these data, we went to the FDA in December of 2020. They held an advisory committee. Norm Stockbridge, who's the director of the cardiorenal division at the FDA, made the comment, a p-value of 0.05 has no basis in law, either federal or natural. I thought that was pretty interesting. We presented these data. The AdCom voted overwhelmingly to approve an expanded indication for sacubitril/valsartan, which now has been, was indicated in February of 2021. The new indication reads that it is indicated to reduce the risk of cardiovascular death or hospitalization for heart failure in patients with chronic heart failure. The benefits are most clearly evident in patients with left ventricular ejection fraction below normal. And then I thought it was pretty interesting. They went on to say LVEF is a variable measure, so use clinical judgment in deciding whom to treat. So this indication is now available in the United States, of course, and we've been using this therapy for about a year. But in addition, the extended indication has been approved in about 20 other countries so far. We've looked at how many patients we think this would potentially affect and how many heart failure events by using this therapy we could potentially avert. This is integrating data from NHANES and Get With The Guidelines with the estimates from Paragon, from my colleague Muthu Vadaganathan, in which we estimated that you can reduce up, there would be up to about 1.8 million newly eligible patients, and you could potentially avert about 182,000 heart failure events. So let me switch my attention now to the new kid on the block, Sglt2 inhibitors, which of course, as you know, are drugs that were developed for reducing glucose in patients with diabetes. They work by blocking resorption of glucose and sodium in the proximal tubule, and they had been shown to prevent heart failure in diabetic patients who were tested in the DECLARE and CANVAS and EMPA-REG trials. But we also were able to show in DAPA-HF, the first trial to test an SGLT2 inhibitor in heart failure, that in patients with heart failure with reduced ejection fraction, you could reduce the composite outcomes of cardiovascular death, heart failure hospitalization, or urgent heart failure visit by 26%. That was essentially reproduced in the EMPEROR-reduced trial with a very similar overall treatment effect a couple of years later. And this has now become standard of care in patients with heart failure with reduced ejection fraction with a class 1A indication. EMPEROR-Preserved tested this in heart failure with preserved ejection fraction in about 5,988 patients with or without type 2 diabetes, evidence of structural heart disease, or heart failure hospitalization. And they were able to show a 21% reduction in cardiovascular death or heart failure hospitalization that was primarily driven by heart failure hospitalization, with somewhat less of an effect on cardiovascular death. Interestingly, in post hoc analyses of EMPEROR-Preserved, they also saw this hint of heterogeneity, that there might have been a decline in the benefit in the patients in the highest ejection fraction category, here over 60% and here over 65%. Is this real heterogeneity, or is it a random subgroup finding? Well, we're going to have to wait till the next trial that I'll tell you about in a second. Why might we see a decline in benefit as ejection fraction goes up? Well, one of the reasons might be that we know that there are many comorbidities in these patients, and they seem to be more important in contributing to these patients' risk as ejection fraction goes up. And these are some data that we've recently published from the Paradigm and Paragon program, showing that if in patients whose ejection fraction goes up, the contribution of the demographic components to their risk, like age and sex, and their non-cardiac components like diabetes and body mass index and so forth, becomes greater compared to the cardiac component of their attributable risk. And therefore, the therapies that we have that are focusing on the cardiovascular aspects may be less effective at reducing risk than in patients with heart failure with reduced ejection fraction. Well, the most recent guidelines have given SGLT2 inhibitors a class 2A level of evidence B indication for heart failure with preserved ejection fraction. Sacubitril valsartan is a little bit lower at a class 2B. I will be presenting the data from the DELIVER trial, which is the second heart failure with preserved and mildly reduced study. I'll be presenting these data at the ESC. It is very similar to the EMPEROR-Preserved study in concept. Patients with an EF over 40%, evidence of structural heart disease elevation and natriuretic peptides. But there are a few important differences. We actually allowed patients in this trial who were either ambulatory or hospitalized, and EMPEROR-Preserved had excluded patients in hospital or within 30 days of a hospitalization. We also included a group of patients who have been excluded from every other study in this area, which is those people who had had a prior LVEF of less than 40% that had recovered to over 40%, the so-called improved patients. We also, our endpoints are a little bit different. We including urgent heart failure visit in our primary endpoint. This trial is a little bit different in terms of baseline characteristics from some of the others, but very similar overall to EMPEROR-Preserved. We have fewer women, as did Emperor Preserved, than in Paragon and TopCat, primarily because we lowered the ejection fraction to 40%, whereas those trials had an EF cutoff of 45%. We also see more use of MRAs in these patients. We're up to about 39% use of mineralocorticoid receptor antagonists in this group of patients. I'm very excited about the fact that we have 18% of our patients in DELIVER who have heart failure with improved ejection fraction. This is recently codified in the most recent guidelines as those with previous LVEF less than or equal to 40% and a follow-up measurement of LVEF greater than 40%. So we'll see what these data show as well. These patients look a fair amount different. They tend to be a little bit younger. They tend to be mostly class 2. They have EFs that are lower, NT-proBNPs that are about the same, but they have a medication profile that looks more like heart failure with reduced ejection fraction. Now, the elephant in the room here is that we've already announced the top-line results of DELIVER, and I will tell you that DELIVER didn't meet its primary endpoint, reducing the risk of cardiovascular death or worsening heart failure in these patients, but I can't unfortunately give you any more information until the ESC. If I did, I'd have to kill you all. But please tune in late August for the DELIVER primary results. There are other pharmacologic trials that are ongoing now. We're about to finish recruitment in the fine arts study that is testing the non-steroidal MRA finerenone. It is a more balanced MRA than spironolactone in terms of the effect on the heart and the kidney, which theoretically should translate into a potentially better safety than spironolactone, which, as you know, has been an issue with MRAs in general. And there's already evidence from the Fidelio and Figaro trials of benefit in a CKD population, and interestingly, significant reduction in heart failure hospitalizations in those patients as well. Ultimately, I think we're going to be treating heart failure with preserved ejection fraction similarly to how we treat heart failure with reduced ejection fraction with multiple therapies. This is an estimate of potential treatment benefits that we might see if we treated our patients with HFpEF with ARNIs, if appropriate, MRAs, and Sglt2 inhibitors. And you can see that this treatment benefit ranges from about a 40 to 50% reduction in a composite endpoint of cardiovascular death or heart failure hospitalization with combination therapy. So in conclusion, the therapies that we've shown to be successful in heart failure with reduced ejection fraction also show evidence of benefit at higher EFs, some more than others. Sglt2 inhibitors thus far have proven the most effective of all the therapies that we've tested in LVEF greater than 40%, and will become standard of care therapy in heart failure with mildly reduced and preserved ejection fraction. I believe that there may be some therapeutic heterogeneity to HFpEF. Several of the trials of neurohormonal modulators have shown declining benefit with ejection fraction going up into the normal range. So we are very comfortable now, I think, in this zone here. I call it my comfort zone. We're still a little bit uncomfortable with patients with heart failure with normal ejection fraction, and we're not entirely sure yet how to treat them. We'll see if DELIVER provides any, informs us at all with respect to that. And then I believe as we better understand the etiology and pathophysiology of HFpEF, we expect to see more targeted therapies in patients with very specific phenotypes. The good news is that clinicians now have several options with various degrees of evidence for the treatment of patients with heart failure with an left ventricular ejection fraction greater than 40%. So Arvind, I will stop here and thank you very much for your attention. Happy to take questions.
Thank you, Dr. Solomon, for that very informative and important topic, heart failure, preserved ejection fraction. My question to you was that, practically speaking, when you see patients who have preserved ejection fraction in the clinic, Now we have these options, and there's Sglt2 inhibitors, there's sacubitril valsartan. Which drug, and of course we have aldactone, which drug do you start first? And how do you manage these patients ongoing?
So I'm glad you're asking me this question now, because the answer is going to be different than I would have answered a year or more ago. But I would say that based on the data that I've presented, currently the first thing I would do, of course, is to make sure we don't have one of those other diseases. So I'm sending more patients, especially men with high ejection fractions, for scintigraphy to rule out cardiac amyloid. I'm also being more aggressive of making sure that there really is a problem with their heart. I want some evidence of natriuretic peptide elevation in these patients before I'm going to commit them generally to these therapies. We use diuretics, of course, for decongestion in these patients routinely, and that really hasn't changed. I have been using spironolactone for many years, but I'm very cautious in using spironolactone when eGFR is below 60, because I've run into trouble with these patients. We don't have that same problem with sacubitril valsartan. In fact, the opposite. We see greater efficacy with lowered GFRs with sacubitril valsartan. So in a patient with heart failure with mildly reduced ejection fraction through the normal range, and I would probably use a slightly different cutoff than women, than men, higher in women. I am treating these patients with sacubitril valsartan, which we're finding no problem, at least so far, with payers in supporting that in appropriate patients. Sglt2 inhibitors, I think, should be standard of care now, based on Emperor Preserved, but also at least knowing the top line results of Deliver. They will be. The problem is they're actually harder to get these drugs paid for in many of our patients, but that will change. And so I think that regardless of ejection fraction, we're going to probably be using Sglt2 inhibitors, and then depending on EF, sacubitril valsartan, and then there will be patients in whom I will use all three agents as well. With both an Sglt2 inhibitor and sacubitril valsartan on board, it turns out that MRAs are probably somewhat safer, because we've shown both in the Paradigm study and also in the DAPA-HF study that patients receiving either sacubitril valsartan or an Sglt2 inhibitor are better able to tolerate being on a mineralocorticoid receptor antagonist.
Thank you for that eloquent talk and actually clarifying some of these practical clinical questions that Maharaj asked. I want to remind our viewers to send in the questions as we're having the discussion to pollev.com. You can enter DeBakey and type in your question, or you can text DEBAKEY DeBakey to 37607. Dr. Solomon, you eloquently pointed out certain kind of limitations and nuances in the clinical diagnosis of this syndrome, especially now that we have these therapies. Congestion kind of becomes a core concept that we're talking about when we say clinical heart failure for these individuals, because they're short of breath. What do you think the role of two things? One is right heart cath, maybe with exercise. In people, it's not overtly obvious on congestion. And then two, do you think ambulatory cardiomems measurements to actually diagnose people, if you're not too clear, what do you think those as a crux for diagnosis for HFpEF have a role?
Yeah, great question. And I think that we probably underutilize right heart cath when we have diagnostic dilemmas in this population, particularly people in whom we can't tell if the problem is a problem of their lungs or their heart. I mean, as we know, many of these people have multiple comorbidities, including lung disease, and it can be challenging sometimes to distinguish these. But I think you make a very important point that many of these people are actually okay at rest. And then they exercise and they get into trouble. They get very short of breath. You can demonstrate that filling pressures actually go up on exercise, so you can do right heart cath with exercise, and that can be a very effective way of determining if during exercise their filling pressures go up. Remember, many of these people have very small hearts, very low stroke volumes, and because their longitudinal function, as I mentioned, tends to be reduced, they can't augment their stroke volume during exercise the way a normal patient can. And that means that when they exercise, their filling pressures are almost certainly going to go up. You might not see that, though, if they're at rest. So I think we should be using right heart cath more. With respect to CardioMEMS, I see it more as a management device than a diagnostic device, especially if you can use right heart cath with exercise. But I think there is a real role for devices like CardioMEMS, and there are going to be a host of others as well, as the technology improves, that will help us manage these patients more effectively.
Dr. Solomon, we have some questions from the audience now. So there's a comment first. Thanks for the awesome presentation. And it's a two-part question. So I guess I'll read out the first part. In DELIVER trial, why put the subpopulation of EF greater than 60% analysis into the primary endpoint instead of secondary endpoint? That's part one. And number two is, since DAPA-HF has over 30 sub-analyses been published, would DELIVER trial do so? Could you share some of the future plans for DELIVER trial?
Okay, well, first of all, very sophisticated question. Obviously, somebody asking this knows the DELIVER statistical analysis plan very well. We actually did something pretty unique, I think, in DELIVER, in that we had a dual primary endpoint that consisted of both the full population and the patients with an ejection fraction of greater than 60%. Why? Because we had seen in other trials that the patients with an EF that was below 60% benefited the most. That was true in Paragon, it was true in TopCat, it was true in Charm. It might have even been true in Emperor Preserved, although we didn't know that when we made this decision. So we said, let's hedge our bets, and we're going to split some of the alpha that we have between those two. And the way it works is that we simultaneously test in the full population and the below 60% population with less than full alpha for each. So you can't win with a p-value of 0.04 with either of them. You have to be below 0.035 in one case and 0.028 in the other case. But then if you win overall, then you can, or if you win in one arm, you can go recycle the alpha back to the other arm. It's a unique statistical tool to be able to essentially hedge your bet a little bit, but you pay a bit of a price in that if we won with a p-value of 0.04, if we had a p-value of 0.04, we would not be able to claim significance. And the other part of the question is, do we hope to learn more things from DELIVER? Yes, we won't stop with the primary result, because we feel like it would be a shame at best and maybe unethical at worst to not learn as much as we can from the patients who we enrolled in this clinical trial. And there'll be a lot of things that we'll be able to learn from DELIVER. One of the interesting things about DELIVER, I should mention, is that it happened during COVID. We had nearly 600 patients who were diagnosed with COVID during the course of the trial. That's about 10% of our whole population. And we had about 150 or slightly more than that COVID deaths in this population, which was a very high percentage of our total deaths. So we're certainly going to learn from that and hope to share much of the data at the ESC, at the Heart Failure Society of America, and then in the upcoming American Heart Association as well.
Thank you, Dr. Solomon. Just to wrap it up, we're at the hour. Just one final question, I guess, is that I see a lot of reluctance from various clinicians and cardiologists to start these medical therapy in patients who have either mid or preserved ejection fraction. What would be your final message to the broader audience that, how important is it to start these medications in a timely fashion?
Yeah, I mean, I think we've waited for so long to have any evidence-based therapies for heart failure with mildly reduced and preserved ejection fraction. We should seize this moment, honestly. And I am really happy when I see a patient, I'm about to go do that in a few minutes, who I feel like I have something I can say, hey, there's now a therapy that might make you feel better and might prevent hospitalizations. And that's certainly how I think about it. There's a lot of inertia when we have 15 minutes to see our patients, to put them on a new medication or to replace an existing medication, but I think our patients will thank us.
Well, we want to really thank you for your time and insight into a topic which is much needed, and I think your last few comments of words of wisdom in making sure we break that inertia and treat this cohort of patients, because finally we have therapies, are definitely golden. We appreciate your time and thank you so much, and we look forward to your future visit to Houston. Thank you.
Thanks so much for having me.